Good evening and welcome to Arizona Horizon. I'm Ted Simons. A controversial new way to administer Medicare is coming to Arizona by way of a pilot program that looks to reduce wasteful and inappropriate services. It's controversial because it calls for pre-approval for select medical treatments. To learn more on this, we welcome Dr. Swapna Reddy. She's Assistant Dean at ASU's College of Health Solutions. Swapna, good to see you again.
Nice to see you.
All right, let's talk about this. This is a Medicare pilot program. Now, pilot programs are like, hey, you want to be involved? Yeah, let's be involved. That's not involved here, is it?
Well, less so. So 6 states have been chosen by the Centers of Medicare and Medicaid Services, and those 6 states include Arizona. We're one of the states that have been chosen for a 6-year pilot program. And what that program will actually entail is that traditional Medicare, so fee-for-service Medicare, traditionally, usually not subject to prior authorization, about 16 services, and that could expand, will be subject to prior authorization, prior approval by the insurer before your healthcare provider or the health system can provide certain services or fill certain prescriptions.
Give us an example of prior authorization.
Yeah, so prior authorization, basically, if you are in the healthcare field, you know it really well. If you are a patient, you may or may not have interacted with it. What it basically states is that your insurance company, your payer, has to approve certain treatments, certain medications, certain processes, not emergency processes, but most healthcare is not an emergency setting, right? Before your provider can know that they will get paid or reimbursed for that treatment. And often what the insurance company is asking is this basically the least expensive way to provide this treatment? Is there a less expensive, less arduous, less extensive way to provide this treatment or get this medication on board?
I want to get back to those questions in a second because it sounds like those are the kind of questions that could bog down a medical practice quite. Well, let's do it. I'll ask it right now. I mean, if you're a doctor dealing with this, this can't be great news.
Yeah, so you might not be surprised that the concept of prior authorization is not particularly popular among physicians, clinicians, healthcare systems. So I'll give you some quick stats. At sort of your average doctor's office around the country, they submit about 40 prior authorization requests a week. They spend about 10 to 12 hours just on prior authorization. That's not just submitting, but that's having conversations with the insurance companies, that's having conversations about appeals, et cetera. And about 25% of all prior authorization requests are denied on the first run.
Wow. Oh, and this prior authorization method, this is used with private Medicare situations. First of all, we hear Medicare Advantage, we hear all sorts of other things. Yes. Explain the process, explain the formula here.
Well, really quickly, Medicare Advantage is an option for Medicare recipients where they can supplement or add on services by purchasing into the private health insurance system. So prior authorization is actually quite common in the Medicare Advantage system. It is really, really rare in the traditional Medicare fee-for-service system. And this particular pilot program is going to be affecting the traditional Medicare system.
Now, I understand AI, machine learning will be used alongside clinical treatments and clinical assessments and these sorts of things. How does that work?
Yeah, so we're learning this every day. We're learning the plans every day. But as it's been stated, basically, if there is a request for particular authorization for one of these 16 types of treatments, there will be some AI algorithm that will be applied. And based on the algorithm, which we're not exactly sure what that algorithm looks like yet, the insurer will decide, or the private contractor that the insurer is working with will decide if that treatment is approved or not. What the insurers have told us is the ultimate decision will not come from the AI formula, but will come from a clinician who will review what the AI recommends.
These 16 conditions, what are some of them, A, and B, why were these chosen?
So a common condition is skin replacements or kind of treatments that have to do with wound management, which tend to be fairly expensive. And there is some evidence that there's some waste associated with the costs associated with wound management, which is very common for Medicare patients, right? Also things like incontinence, nerve management, pain management, et cetera. So these are kind of the types of treatments that are most commonly listed in that list of 16.
But why would nerve and pain management be is that subject to what we've seen in the past, some sort of waste and fraud and such?
Well, according to the experts at CMS and those that have designed this program, they're stating that some of these processes and some of these treatments, there is some evidence that there's high waste for some of these procedures, and it's interesting because they haven't necessarily listed all of the procedures where there's high evidence for waste. So we're going to see what it's like for these 16. It's going to start in January, and right now it's scheduled for about 6 months. 6
months or 6 years?
Sorry, 6 years.
6 years.
Yes,
okay.
yes.
It's called the Wasteful and Inappropriate Service Reduction Model. WISER, I think, is what.
Yes.
Okay. Has there been wasteful and inappropriate service out there? Is this in some ways a good thing?
So it really depends who you're talking to, right? If you ask the health insurance industry, the answer will often be, look, there's a history of some waste, there's a history of some abuse, there's a history of some fraud in the healthcare system, and I think that that's somewhat undeniable. And this is an attempt at solving that problem. The evidence kind of shows about 5 to 7% cost kind of savings annually based on prior authorization. Now, if you ask providers and healthcare systems, what their answer will be, well, but we're spending billions of dollars in just the administrative requirements. Around 40% of all doctors' offices have someone hired just to handle prior authorization. So this is a huge administrative challenge, huge administrative cost that often gets passed on to the patient.
And we've also heard from critics of this particular idea and this pilot program, this is a backdoor way to privatizing Medicare. Is there any point in that?
We'll have to see, because again, this is somewhat unprecedented. We generally have not had a system like this or an approach like this, especially with traditional Medicare. We don't really touch traditional Medicare. I mean, something else that's also really interesting is that the companies that will be contracted for the AI review, there is a profit sharing arrangement as well. So at the moment, there's a profit sharing arrangement. So those companies will receive some kind of profit for the waste that they've saved the federal government.
Oh my goodness! So there's a little commission there going on, huh?
As it's stated right now.
Interesting. All right. Is there any opting out for anyone in any way, shape, or form with this?
So as it's stated, providers, clinicians, health systems they need to opt in to this system. But what's really tricky here is that even if you have not opted into the prior authorization process for these 16 processes, there can be a post review of how you treated said one of the 16 issues, right? And you can still be denied reimbursement if the AI generation and if the review determined that you did not provide the correct treatment or the least expensive treatment.
And I would imagine a post-review would be even more administrative work, would it not?
Well, it would. And remember, when we're talking about these reviews in general, we're not as familiar with the AI reviews, but we generally have other clinicians, independent clinicians that generally work for the insurer or contractors that are reviewing the treatment, reviewing the prescriptions. There's usually conversations between the prescribing physician and the reviewing physician, sometimes not always the most pleasant, and also the administrator at the physician's office or with the healthcare system. It's a process, and you can appeal, but lots of patients don't appeal. And so I think there's a whole navigation to this process.
And last question, real quick, because we're running out of time. But it seems like this is flying awfully low under the radar here. When this kicks in January, are we going to see a hue and cry in February, March, and people are going, wait a minute, what's going on here?
Well, I guess we'll see. We'll see what the actual effects are. What's really interesting is that the Trump administration has been really proud of the fact that they've actually lessened and streamlined some of the prior authorization requirements around Medicare Advantage. So it was a kind of fascinating decision to institute this new approach just a few months later. So we'll just have to see how this affects patients and the healthcare system.
Dr. Swapna Reddy, ASU College of Health Solutions, always a pleasure. Thank you.
Thanks for having me.